lab values. This is something you're going to see very often in clinicals when you're working. They're always going to talk about lab values. So normally you want the white blood cell count to be between 5,000 and 10,000. Now depending, this is per microliter of blood, so depending on what unit they have, it may say 5.5 to 10.0. I know at Children's we use 5.5 to 15.5, or 5,500 to 15,000 as our normal range. So anything that would fall below or above would be leukocytosis or leukopenia. Leukocytosis is when the white blood cell count is going to be higher than normal, so it's going to be over 10,000, and this would indicate inflammation or infection in the body. And leukopenia occurs when the white blood cell count is lower than normal, so that would be under 5,000. And usually even worse than that, below 1,000, would be an increased risk of infection. And it would also, anything behind, even below 500, would be a serious life-threatening infection, which could result from things such as radiation therapy, chemotherapeutic agents, which literally breaks down the body, kind of kills the good cells that you need, but because of the cancer that's there, that's why they're being killed, which then obviously makes the patient immune compromised, so they have to be very careful about where they're at, what they're going, who they're around, because of the infection. Systemic lupus, vitamin B12 deficiency, cortisol treatment, and anaphylactic shock. These are all things that just break down the body's immune system, make it very susceptible to infection, which could then cause a decrease or increase in the white blood cell. Usually the decrease is the one that we're going to be more worried about. But the white blood cell count can also be attributed for appendicitis. That's a big one they look for. Mononucleosis. Yep, mono, have a high white count because your body's fighting off infection, which then makes your spleen get bigger because it's trying to take care of all your white blood cells are trying to work so hard, so your spleen gets big. All right, look at that. That's a little bigger than my fist. It's blown up. Just like when we scan. I always have patients, whoa, that's really big. You say, well, we're only about 4 centimeters in. It's just blown up. So that's what a normal gross specimen of the spleen looks like. Really pretty. Very red.
Lindsay, you said earlier,
yes.
I don't know if Rachel's used that terminology before, but you hear it with spleen and liver that it's friable.
Oh, yeah.
Have any of you heard that word before?
So I just asked her, did she say friable?
She did say friable. Have you heard that word before?
Sorry. It means it's very brittle. It's very, how I was saying, it's susceptible to getting hurt and injured. Friable just means it's soft, spongy. I think that's kind of the best. It's very susceptible to getting damaged because it's so soft.
That's called friable.
I'm trying to think of a good analogy.
You can't put it in a skillet also.
Yeah. Friable, right? Woo! Put it in a pan. That would taste too good. Okay, we're scanning. Okay, so now we're going to talk about scanning. So when we have a patient come in, what's our protocol for scanning? Okay, first thing, the patient should be NPO, but obviously to get the best image, but it's not required. Usually it will help us decrease some of the gas, especially in that leftover quadrant. Remember I kept saying the splenic flexure of the colon is very close to the spleen, and usually your colon is going to hold more of your dense air than the small bowel would. So by having them NPO, they may not have as much gas. Although some people just really transducer, what do you want to use? You want to use the low frequency transducer. Obviously the smaller patient you have, you'll be able to use a smaller frequency of a transducer. If you're looking for certain pathology, you may even want to put a linear probe on, depending on how big the patient is, obviously, as well. Patient positioning, you're going to probably start with them supine, but most of the time you're going to have them up on the right side, right lateral decubitus, or right posterior oblique, or their left arm raised over their head, and on their side. That's going to open up these rib spaces really well so you can get in there and take a good image.
So smaller patient, higher frequency. Okay.
Bigger patient, lower frequency. So I found this really cool picture, kind of give you something right here. So we're going to scan. And I know for a while it took me a while to kind of figure that out. If you think in your head how a diagram would be with the ribs. You think of the ribs how they come down at an angle. They're not completely along. So when you're scanning in the just start long, like, okay, and then just kind of turn your probe a little bit to get in those spaces, and you'll be amazed at how much you can really get in there. Sometimes you can even ask a patient to hold their breath or blow all their air out. Everybody's a little different. Sometimes when you have them hold their breath, though, it pushes the lung into the picture. But usually you can have them just push all your air out and don't breathe. And then sometimes you can get that image right there and not have to worry about going between the ribs. So we're going to take longitudinal and transverse images. Coronal approach is best. We're going to measure that long axis like I talked about before. Remember on our picture of the spleen, like this, kind of journaling it. Measure the long axis, measure any pathology, and earlier said Doppler the splenic vein. You want to make sure if splenomegaly is present, you want to make sure it's not due to a thrombus, or you want to make sure that there's good direction of blood flow in the splenic vein. And obviously because of the portal splenic hypertension, portal hypertension. The echogenicity of the spleen is going to be very close with the liver, isoechoic, and slightly hyperechoic to the kidney, slightly brighter. It's very finely homogeneous. The reason why it's very finely homogeneous compared to the liver, sometimes the liver has more of a contrasty look to it, whereas the spleen is a lot more smoother because it has less vascular. It's very less vascular than the liver. How we talked about the artery, how it doesn't have all the branches like the liver does. That's why you're going to see it sonographically is going to be a little bit different. Alright, so these couple images that we have, I'm pretty sure these are from your text. I don't know, it must have cut off. I had references where all the images came from at the bottom. I must have cut this one off. But first picture, see our spleen. Very pretty. And then here, what do you think it's pointing to in these images? This B and D. What do you guys think that's pointing to there? Yep. Now, how would we be 100% certain it was splenic vein? Yep. And then we're still confused? Doppler. Good job. Yep. And then right here we can kind of see how our spleen is a little bit more echogenic. Right? It's more hyperechoic. Yep. A little bit more echogenic than our kidney. I know that picture is kind of hard to tell. It's so subtle. Some people wouldn't even call it that, but
Changes with age too.
yeah, changes with age. Alright. Clinical manifestations and indications for a spleen ultrasound. Why would we be doing this? So we know what we have to do. Patient BNPO if we can. We know how we have to scan and what transducer we have to use. But then why are we doing the exam? Usually due to abnormal lab values. So what lab value did we just discuss that would be very indicative of doing a spleen ultrasound? Right? Yep. And history of infectious disease. We want to know, have they been out of the country? Have they ever had cancer? Do they have mono? Have any things like that? Because a good patient history is going to tell you what you need to think about. Okay, when I'm scanning this patient, if they just had an accident or fell off a bike, what do I need to look for? So that'll also help you clue in, because then when you find something, you're not like, what do I do now? Oh gosh, I forgot what to do. And you will. The first couple times you find something abnormal on a patient, your protocol just goes out of your head. And you're like, oh, I forgot what I need to do. What do I need to take pictures of? And you kind of get stressed. I know I did. I kind of freaked out at first. But then you worry about taking your protocol pictures and you come back. And you're like, okay, now I know I need to do this. I need to put color Doppler on. I need to measure any pathology. I need to make sure that, does this go out of the spleen? Is it within the spleen? Or am I just seeing splenomegaly? Things like that. Leftover quadrant pain. Palpable enlarged spleen, which we would normally see with any type of infection. Most of the time you'll hear enlarged spleen, leftover quadrant pain, mono, recently diagnosed with mono. And sometimes they just want us to say, yeah, the spleen's big. You were right. Spleen's big. Alright, so now we're going to talk about congenital anomalies, things that can go wrong with the spleen. Asplenia or aplasia, and obviously congenital means from birth, right? Asplenia or aplasia, which literally is the absence of the spleen. That means the patient is actually born without their spleen. It's rare, but it is usually associated with other severe defects, usually cardiac anomalies. You'll learn a lot more about this in echo and OB as well. But if I went into it right now, you guys would all be like, oh my gosh, are you serious? Too much information too fast. And let's see what we have. Polysplenia, same thing, very usually commonly associated with congenital cardiac anomalies, and it's just where you have multiple spleens. Sometimes it looks lobulated, or maybe you have a round spleen here, and you got another piece here and another piece here, or if the child has situs inversus, maybe the spleen's over here. You have multiple little things that look like dilation seen on the medial aspect due to diffusion of the splenic lobules during embryology. Alright. Congenital anomalies, we've got more. Ectopic spleen, which literally, do you guys know what ectopic means? Yeah, say again? Yeah, yeah. It can be anywhere along the left side. So usually your spleen is tucked way up under your ribs, way up in here. If the spleen's down here, that's not normal. If it's way back here, not quite normal. So, and also in right upper quadrant, situs inversus, I just kind of mentioned that a little bit, or situs transversus or appositus, when organs are on the opposite side of the body. So say you have your spleen on your right side, liver on the left side. That'll throw you for a loop if you ever have that patient. Wait a minute, this is not right. This is not right. Or say you're first scanning the patient, and you're the first one to ever scan them. They never knew that they had an issue like this. Usually, probably no, but every once in a while there may be a patient that didn't know that they had something going on. Or there's even where the liver can be right in the middle of the belly, so then the spleen could be on either side. I've seen that before in a child with congenital cardiac anomalies. The spleen, they call it a transverse liver, because it's right in the middle, and then sometimes the spleen can be on its right side over here, or it can be on the left side. Wandering spleen. Wonder what that means. I know, say that. Migration of spleen from the left upper quadrant. So it just decides to go somewhere else. The ligaments, I didn't discuss any of the ligaments because it's not something that's hit hard on the registries, but was in your homework. So those ligaments, the gastrosplenic ligament, and the other two, because it's so loosely held, the spleen is, which we want it to be because it needs to get bigger when we fight infection, even if it's a little bigger. But because of that lack of the ligaments being so tight, the spleen can actually kind of move around a little bit. And it's usually caused by weight loss, splenomegaly, or pregnancy. It's usually found in the left flank or left lower quadrant, so it just kind of migrates down this area here, comes back here. And can be fixed with splenopexy, which literally means to tack the spleen up. So they would literally just tack it up in the left upper quadrant where it's supposed to be.
That cause pain. What do you think it's
The splenopexy?
Level wandering.
I don't know. You know, it might if it's in an anterior spot where it could get hit more often. But, I mean, even up here, your spleen is very susceptible to trauma and, getting hit frequently because your ribs lie over a little bit. It does help. So I would imagine that it would. I'm not 100% sure, but I would think so. Especially, let's look at this image here. This is actually a wandering spleen right here. And obviously you can tell they're looking at it with a linear probe. And down here in the little annotation that talks about it, they say that it is a newborn with a palpable abdominal mass. Shows a spleniform mass, the white arrows, and no internal vascular flow. Which you wouldn't think of with a spleen, but does this look like a finely homogeneous spleen? No. It's probably got some infarction. Maybe it had some trauma. Maybe just because of where it's